my colleague Daniel Hagara, he has an emergency, family emergency, so he couldn't attend. I will bring you 3 cases for interactive discussion, and please discuss with me and with the others on the effectively on the. Oops. Yes. So the first case is this one. We see here in segment 8 and segment 4, we see 2 lesions. And this is a representation with a high mechanical index after a serious examination, just turning up the acoustic output. So it's just to show it in a better way. This is normal before serious, and this was then after serious. What do you think about this lesion? If you don't know anything, you think maybe it's a malignant lesion after chemotherapy, and it was like this. It was a lipiodol 5 years earlier, and the new lesion here was a little bit difficult to understand. So we have here a 70 years old patient. He's known for NASH hepatopathy. The FibroScan, please note, this is only F2. And chemoembolization of this likely hepatocellular carcinoma at segment 8 was performed on February 2012 without no histological assessment. Due to claustrophobia, the patient is lost to follow-up. A CT scan done 4 years later gave a strong suspicion for HGG recurrence, and a CT scan 6 months later, because then he went away. It's, normally we have these patients that are not very compliant, and some months later he arrived in the ward, and we performed a new CT scan. And in the CT scan, we have seen the second lesion in the segment 4A. So what? Laboratory findings. Everything is in normal limits. Blood cell, platelets, liver function, total bilirubin, ENR, hyaluronic acid not very high, AFP and ferritin. But he was he is homozygous for PNPLA3. So we have the CT scans 2016 with this lesion at the 8th segment. Then the later CT scans some months later, same lesion and the new lesion here. So this was important for a discussion in the board, because in the portal venous phase there was no washout visible. I can't run it again, but there was no washout visible in this portal phase. So, what is the hypothesis? First, is this HGG in both segments, HGG relapse after TACE, or a dysplastic nodule in segment 4, HGG post-TACE, solitary necrotic nodule in segment 4A, or echinococcus. I think the echinococcus was suspected by the presence of hyper intense material that was attributed to calcium, to calcification. But the serology was negative. So I think this was already ruled out. What do you think? What is the most interesting pre-test assessment of this case? Is this HGG in both segments? Is a relapse after TACE in segment 8 and this plastic nodule segment 4, or a HCG post-TACE and a solitary necrotic nodule in 4A. What do you think about the first hypothesis? What would be before performing those?
So first hypothesis, raise your hands.
Yes?
Second, raise your hands. Second hypothesis. Third hypothesis, raise your hands. So there is just one for the first.
One for the first. Okay. All right. That's very good. This was the same discussion we have had. Yes. Absolutely. It's coinciding. Yeah. Okay. So show it again. This was 8 for A. So we let run now those. Here 6 seconds. Here now it's arriving 15 seconds. Enhancement in both nodes. We go on. ISO echoic afterwards. 30 seconds. This is really very difficult. Huh? I run it again. Okay. Hyper intense. Both. Okay. Now, later. 1 minute. What's happening here?
Is it the same position of the probe? I think you changed. So we see a different part of the...
No, but it's about the same, I guess. Oh, it's the same. But now we see here a slight washout, I guess, huh? And then the washout was more pronounced after 3 minutes, and then even visible after 3 minutes, 2 minutes, 3 minutes, and here after 4 minutes. It wasn't. Yes, it's. I think for technical problems, then you can't see anything anymore. So the interpretation of this source was, for us, was a positive result, despite the negative result in the CT scans. Do you agree that this was a positive? Yes. Yes. Okay. So we see what shall we do. What shall we do now with the result? We use a lot of this curve, this Bayes theorem, and I think we should remember this theorem of 1700 and something of this English pastor that really gives us in a clinical practice, a clinical general practice and general ward, a lot of information. This is the pre-test probability for maybe in our case for a tumor, for HCG. This is the post-test probability. And here is the curve of the exam. If the exam is positive, this curve. So if it would have been negative, the curve would have been like this. So you can take a probability, and what do you estimate now in base of this ultrasound? Negative CT and positive ultrasound. What do you think as pre-test probability? Where would you push the? 8. Okay. so we go up, and we find here the intersection, and so it is a very high probability of a HGG. So this was the decision, and the decision was after a lot of discussions, because there were a lot of discussions with radiologists, of course, and they weren't convinced about. And then in Bern, Candinas.
May I ask you, what is the alternative possibility to treat this patient? Just to wait and take a biopsy?
But he's a waiter. He has waited for years, and then 7 months and so on. I think it's dangerous to wait.
I agree, but say there was a lot of discussion. So I was wondering what was the discussion, because on one side I would see someone who say we go directly to treatment, and what do the other tell?
Mhm.
Wait and see and take a biopsy. Or
No, I think yes. What is to do? Yes, a segment resection would be a possibility. A biopsy would be a possibility, but segments are not very easy to reach. I guess it's under it's 8 and 4A. It's yes. So the discussion was to intervene surgically, or to just to wait and to do it in 6 months' time again. Yes. Because the patient was absolutely against any intervention. He lived in Spain, or he's living in Spain, and he told him, no, there's nothing, I feel fine, and so on. And then it was possible to convince him then, for the surgery. Yes, please.
Although it may have been difficult to reach on ultrasound, with the lithiodol there it could be a marker for...
Yes, so it's a very good question. And we really, this could be lipoidol. Yes, relapses. This is possible even after some years, I guess, I heard. So it's a very good question. Yeah.
No, besides, we can, you just, you were discussing the biopsy, because the lesion may be possible to reach on ultrasound, or that we could perform the biopsy.
Now, I think the lesion was not sympathetic. If you're looking at this, with even a high pre-test, high post-test probability. So I think it was important to inform the patients. That's important for him to get the resection, and he agreed afterwards. After the discussion, he agreed. And please,
Without the surgical proof?
no, surgical unit here in Bern.
without biopsy before.
No, without anybody. No, without biopsy. Yeah, just resection. And the decision was like this. It was a decision taken with the hepatologic unit of Bern, and so he was convinced to come to Bern for the resection. And now it's interesting. We have, of course, then the histology, and the histology effectively was hepatocellular carcinoma in both lesions. And there was the lipoidol was very good, a very good question. This could be a confounder, but it wasn't. I think it was a stain here. I guess it's really a calcification and not lipoidol reminder. So that's interesting, and I think I would emphasize the fact that the concept of pre-test and post-test probability is a very important
Absolutely.
context.
Can I ask you a question? Did the pathologist comment on whether this hepatocellular carcinoma could have been an evolution of an adenoma? So on an adenoma, pre-existing adenoma, since the patient had this fatty liver, not really cirrhosis, we know that they can go directly to HCC, but it's often common also having adenoma. So just a question.
Yeah, it was described as a moderately differentiated hepatocal. Yeah, moderately differentiated. And so this was, of course, was the reason why in the CT scan maybe it wasn't so clear. It was not differentiated, but it's a moderately differentiated. Yes, I think, but the idea is to show that the story of pre-test and post-test probability in a clinical setting is even very, very important. Yes. Out of new methods and so on, genetic examination. And I think the problem that, or the one of the factors that induced the surgeons to do the resection was one thing that I have shown first. I have shown you that the patient was homogeneous for this PNPLA3 mutation, so homozygous for this mutation, and so I think this was one of the decision points anyway.
Does everybody know what is the importance of this mutation? Is there anybody having interest in it? So, yeah. So this is a mutation that, when homozygous, increases the risk of progression of liver disease, increases the risk of accumulation of fat in the liver and progression to more advanced stages of fibrosis. In NASH it has a lot of importance, but also in non-NASH related diseases that have been associated to progression. Therefore, I think you do it.
Okay.
You do it usually in
yes,
patients.
Professor Chern is doing it now. Yes,
We don't use it commonly, but I think it's an interesting
he's
information.
Convinced about this, but I think there is
so
evidence.
In this case, you
I
took
think there
into
is a large
consideration that this
evidence,
was
yes, I think
important.
up to tenfold risk if you have this homozygous mutation.
It's not yet considered mandatory in the
I don't
guidelines.
know, yes, but it's a new method.
We have here Professor Dufour, who is the head of the pathology group. Thank you for coming, Jean-François, and is mega expert in FLD NASH, so he might comment on this point.
Thank you, Annalisa. No, I'm not a mega expert, but I mean, it's effective, ein Polymorphism ist sehr wichtig in NASH, aber nicht nur in NASH, wie du hast gesagt, und das erhöht das Risiko. I'm sorry, I have to push the English button. So this is effectively quite an important polymorphism because it's frequent in the population. This is a frequent SNP, and this is associated with progression of the disease, fibrosis, and also the risk of hepatocellular carcinoma, as you said. So this is one of the most relevant genetic tests that you can do. We are not doing it because we are not changing our attitude, or we will not change our management actually currently based on it. There is some data suggesting, interestingly, that in patients with NASH, when you would want to screen or not to screen for hepatocellular carcinoma when they are advanced in fibrosis but not yet cirrhotic, if they don't have this mutation, this SNP, you may actually, they have a low risk to develop cancer, and you may not put them in a screening program. But this is not validated. There's one publication in this direction. Thank you, Annalisa.
Thank you.
It was very useful. Thank you.
Okay.
Yes.
Maybe we move on. Second
Yes,
case.
the second case.
This is second case. This is a case in segment 8. What do you think? If you please, we will talk later on it. But if you see this in segment 8, a slight dislocation of the veins. And the patient, and this is a Doppler sign, like a kind of enhancement in Doppler, or if you know, it's a 65 years Caucasian living in a rural region, but not a farmer. He came for checkup for assessment of arteriosclerosis and aortic aneurysm. That's a good setting for a 65 years old patient. We should do it frequently to exclude aortic aneurysms. He had good general health conditions, normal vital signs, and in the laboratory there was only a slight dyslipidemia. It's a slight steatosis, and this finding always in the 8th segment. Well, what is the differential diagnosis? Is this a benign angiomatous lesion, like a hemangioma, maybe a FNH? Is this an adenoma, because there is a there is like a capsule, a pseudocapsule? Is this a lymphoma, maybe a vascular malformation, or something really rare here? HCC, and of course ICC with special growth, or a metastasis of a GIST tumor, or an abscess maybe of echinococcus. This was the differential diagnosis that was given. And now, what will you do? We're doing choice. So we did a choice. But before doing the choice, I think the abscess is less probable, because there are no vital signs for abscess, and for strange tumors, less important. But maybe the lymphoma, or could be a hypothesis. The adenoma, of course, because it was encapsulated. Maybe the adenoma is not encapsulated, of course, but the adenoma is to be excluded. Or then is the remaining benign angiomatous lesion. What do you think? The first, what do you think? First priority? Is this 1, 2, or 3?
Something different.
1. Okay. Adenoma? Nobody. And lymphoma and so on. Okay. So we'll see. We performed those. Now, nice rim enhancement. Typical rim enhancement. Pedunculi that entering the lesion. Fill in.
I would not call it rim enhancement, but rather globular peripheral enhancement.
Yeah, peripheral enhancement. Yeah, okay. After 3 minutes, like this, isoechoic. After 4 minutes, isoechoic, and after 6 minutes, isoechoic. I think we have used already the pretest probability of our pastor of England, and I think we decided very well. I think it was really a hemangioma. Yes, thank you. It was really a hemangioma. I think evaluating these pictures, we can say that this really major probability it's hemangioma. And then, strangely, looking back 9 years earlier, the same feature. So I say, I have been too courageous 9 years ago, because I haven't performed serious examination. So, yes, it was just a clinical evaluation because the patient was in normal health, and so I thought it was a hemangioma, and I was very happy that 9 years later the situation was the same. Okay, what do you think about this case? Do you find these cases frequently? Because Professor Bru told us now, yes, in the 8th segment, was a malignant lesion. This was his ICC inside, and about the same position. She showed us, no, first. So it's yes, no, but it's peripheral. It's rare. Normally, it's more central, I think, localized. Okay, this is yes.
I think the hypoechoic appearance in the first exam is because the liver is steatotic.
Yeah, of course, yeah.
So, hemangioma can
Absolutely, you are absolutely right. This is a normal representation. Normally, the hemangiomas are hyper-reflectant. Yes?
Concerning the exclusion of diagnosis of abscess, just on the basis of the absence of septic general sign, I think the type 4 could be really this aspect without general signs.
No, it was it was encapsulated. It seemed that it was maybe a pseudocapsule or something like this. So it wasn't excluded. Yes, primarily. I think it's very unusual to have an abscess in this location, and and there is no doubt about it because he is in very good clinical conditions. But you did it right. You voted for hemangioma, and this is a very good thing. You applied this theorem because low pretest probability with a positive test, so we can exclude with high possibility or high probability a malignant process, underlying process. But you know we have to pay attention. Sometimes strange things have then a malignant outcome. So it's always more sure to be really to be sure about the diagnosis. But I think with
65.
yes.
So if you didn't have this information in 2009 and you see for the first time a patient 65 years
Yeah.
old,
Yeah.
I'm not sure the pretest probability of having something malignant is really very, very low. So it's of course lower than a cirrhotic liver. But
Yes, but with this theorem is interesting. I go back again.
I agree that after contrast-enhanced ultrasounds, that's very clear.
Because it was yes, this was negative, yes, for a process. So if you have a high pretest probability of 0.6, you tell me it's 0.6 because it's 65. Okay, we go to 0.6, huh? But I don't think that's more than 0.6. Then the test was negative, so we have a very low probability. And so I think this diagram is fantastic. And this was one of the most clever pastors I think that ever existed. Yes, really. Yeah. Okay. Other questions to this case?
Are there normal hepatic arteries or veins going through a hemangioma? Is that possible? Or is it always expanding and pushing the vessels beside?
I think the second hypothesis, huh? Is correct, yeah? Yeah. Okay. Perfect. Other questions? Yeah. So we move to the third case, huh? Okay, this is clear. This is segment 5, and I think everybody thinks that's a hemangioma. Do you agree? That's a hemangioma. It's classical hemangioma. And
Why?
why? Yes, why it's classic? Because it's hypereconic, echogenic. There is no halo, and there is no extinction of the ultrasound array behind the lesion.
To the left side in the periphery of the
Here,
liver. More to the left side. The large thing there.
here,
Yes.
yeah. I think that's a technical problem. That's a technical problem of the patient moved. Yeah, I think this is not. Yeah, this. Yeah. Here the gallbladder. I think the position in segment 5 is clear. I think the
second nodule beside the echo-rich nodule, which is just heterogeneous.
where do you find?
Directly beside the echo-rich nodule, you have a heterogeneous nodule.
You mean this one?
Yes.
Ah.
I'm not sure.
No, I think this is an artifact. Must be artifact. Yeah. Okay, so it's a common fact. We always see these things, and it's clear for us. It's primary. It's a hemangioma, I think. Yeah? But the problem was like this. Huh? It's a woman born on 45 with a heavy diagnosis, endometric adenocarcinoma, with peritoneal hematic fluid, total hysterectomy followed by 6 cycles of chemo based on carboplatin, taxotere. And the collateral diagnosis is interesting. Diagnosis is a medullary sponge kidneys, because always both. And this PAU is penetrating aortic ulcer in the infrarenal aorta. Yeah. This is the clinical setting of this woman. Since this woman, the clinical follow-up, except the chronic idiopathic pruritus, the patient is in good health conditions without signs of illness relapse. All usual laboratory findings, except a slight dyslipidemia within normal limits. Everything is okay. Last value on June this year, stable on the time axis. Imaging contrast CT of the abdomen 2015 and 16, and PET scan 2016 without evidence of illness relapse. This was ordered by the oncologist, of course. And the focal liver lesion at this segment we have seen before, repeatedly shown then at the conventional ultrasound, was not evidenced neither using CT or PET-CT scan technique. So the oncologist told me, no, this is must be an artifact. It's not possible that this is a lesion because it's not not evidenced in the CT or PET-CT. This was the information. And so it's a little bit clear. We got really there was effectively in 2016 fifth segment nothing. Then we did. Now you see that the other thing was an artifact. Huh? There's nothing. Absolutely a clear lesion in the fifth segment without any doubt. I think. Primarily to characterize as hemangioma. So the differential diagnosis: hemangioma, metastasis of the primary tumor, focal steatosis after chemotherapy, or solitary necrotic nodule. What do you think? First, second, third, and solitary necrotic nodule. One, yeah. Could you tell us something about this nodule, Fabio?
To me, it looks like hemangioma, because if the CT does not show it, how can it be a necrotic nodule?
Okay.
It was with contrast, I guess.
Yeah.
So it could not be a necrotic
Okay. So the most...
metastasis without washout at CT, if it is technically performed in a good manner, should be ruled out. If the radiologist knew that there was a focal liver lesion, for sure he had checked for that, and if he says it's not there, the likelihood of metastasis is very, very small. Focal steatosis could be after chemotherapy, but usually it's not so well defined. So this is a possibility. Hemangioma, when they are very small, they might lack the peripheral enhancement. They might enhance quite rapidly, so they might remain iso-enhancing. So to me, the hemangioma is the most likely, and secondly is focal steatosis.
Okay, thank you very much. Now it was the discussion with the radiologist was like this. No, they thought that this was a problem of the sonographer. Huh? They see lesions that are not depictable then with a correct thing. Okay, so we performed, of course, an ultrasound. The lesion was there. It was to show that the lesion was really in the correct position. We see something here, but there is absolutely no enhancement in the arterial face. "45 seconds. ISO. After 2 minutes, practically ISO. "4 minutes, nothing. And then the oncologist repeated the CT scan and told, yes, we have to look again. There was nothing inside. The same thing. And it was a little bit, yes, this was really inconvenient. But of course I did then the ultrasound again, I have seen the same thing. So it's not possible that you don't see anything. What will you do? What will you do now? If you have a situation like this, you have a positive ultrasound, negative, repeatedly negative CT scans. What do you do now?
But what was the conclusion of ultrasound?
Please?
The ultrasound performed with contrast. What was the conclusion before you?
It was negative. There is no enhancement in the arterial phase. Hemangioma, yeah. And what do you do to confirm the diagnosis then? In this setting of, in this patient setting, I think. Yeah. Yes. So you are changing now the diagnosis. First you told me, no, this is can't be a hemangioma. This was another kind of pathology. But now we are approaching maybe the diagnosis. And what was done then to be really the best thing would be to confirm. Yes, a primo vista with MRI. Yes, and this phase 1. Phase 2, and then I think.
For hemangioma, what is most important is without contrast. You can even avoid receiving contrast if your suspicion is a hemangioma. What is needed is the tissue images.
Okay.
Because in tissue images is full of blood and it lightens up, it becomes white.
That's right.
Differently from any other type of lesion. The EOB, the primo vista is misleading because you see that it shows an nascent defect which might raise a suspicion of metastasis. So if I have to run a study for the suspicion of hemangioma, I would avoid primo vista. I would prefer a gadolinium-based macrocyclic agent, not linear agent.
Not primo vista. Okay. Thank you.
Do you count on the degrees of signal of the different B on diffusion? Or
To use the diffusion-weighted imaging?
Yeah.
Yes.
Okay. So, and this is done 1 month ago, huh? It's absolutely the thing. So it's a hemangioma. So much ado about nothing, maybe. As for a lesion that was since from the beginning relatively clear that this was nothing. But I think the confounder was these negative CT scans and that. Of course, the anamnesis was really.
That you are presented, I would suggest to change the radiologist.
No, there were several radiologists involved. No, we did it in several. It was done in several hospitals. Yes, yeah. Not only in Moncuco. No. And so it was always the same thing. And the oncologist was convinced that no, it must be nothing. Effectively, it was nothing. It was hemangioma.
Solitary lesions smaller than 2 centimeters in oncology patients that are detected at the same time with the tumor in 50% of the cases are benign.
Benign, yeah.
So even the a priori possibility was 50%.
Okay.
No more.
Okay, so thank you for your attention. This is a kidney, a medullary sponge kidney.